Hello, students. I'm going to provide for you today an IV therapy PowerPoint presentation. This is not something that you will be tested on in the classroom. This is part of your clinical experience. Usually what we do is I will do this as groups while some of you are practicing your skills, then the rest of you will do the IV PowerPoint, and then we kind of flip-flop and do it again. But since I cannot be there for tomorrow's clinical, then I'm going to provide this to you as a PowerPoint presentation. So what you are expected to do is that sometime this week you're expected to review this, and we can check the bright space where it's set up, and look and see if it was, if you reviewed it or not. So please review it. Sometime you've got all week to review it, but before next Monday, it needs to have been watched by you. And I would say you'll probably get to go home from clinical, far before 7 o'clock tomorrow. So if I were you, I'd just do it then, and that way that's part of your clinical day, and then you don't have that hanging over your head. This will probably be less than an hour. Usually when I do it and when there are questions, it will end up lasting about an hour. So since I won't be having any questions, it'll be about an hour. Some of this you're going to find to be material that you know well, and that's fine. But there are a few things in here that every semester I find students don't know or don't have a good grasp of. So hopefully as we move forward, there will be some things that are good information to you that you'll use for the bulk of the semester. And a lot of it, probably more than half, will be just review. Okay, so the first thing we're going to talk about is what is an IV? An IV obviously stands for intravenous device. It is a device or a means to give a patient fluids or medications through a vein. So again, should be basic review for you. So it is a device that goes into a vein, and then it is secured down, and then you can run continuous fluids in it, or you can just give medications periodically or fluids periodically. However, in order to keep it from clotting off, if you're not running fluids continuously, you'll need to flush it intermittently, or it will clot. It'll get a clot in the end of the catheter. So I will just tell you, just as a little bit of interesting tidbit, when I first graduated from nursing school, we believed that if you didn't run continuous fluids, that the IV would clot off if you didn't put some heparin in the line. So what we would do with our patients with medlocks, which is just an IV, most of you know, an IV access without fluids running through it, just a little plug on the end. After we finished, let's say, giving IV antibiotics, we would literally do a saline flush, and then we would do a heparin flush. And it was just 10 units of heparin, so it wasn't much. But we did flush with heparin after we flushed with saline, and that made us feel better and made us feel like that it wasn't going to clot off. What we've learned by research and evidence-based practice is that the saline flush was the effective agent. The heparin was not a necessity. So now you only need to flush with saline, and heparin flushes, of course, are out. You need to flush with saline at least every shift. By that I mean every 8 hours, in order to be able to be comfortable that your line is not going to clot off. Okay, so you can put different size tubes into a vein, for lack of a better word, tubes, cannulas, whatever you want to call them, based on what your needs are. So most of you, again, probably know this. And when you put in an IV, you use a needle to stick the patient and put the IV in. And on the outside of that hollow needle is a hollow plastic cannula. Once you get in the vein, you pull the needle out, and what's left in the patient is a little plastic hollow cannula. We secure it to the skin, and we can then, again, set up fluids to run through it, or we can put a plug on the end of it and call it a medlock and make it an intermittent use device. The most common diameter lumens for the cannulas are going to be the ones that you see on your PowerPoint there, 18, 20, and 22. Those are the most commonly used adult lumen for cannulas. So, interestingly enough, in these IV cannulas, the higher the number, the smaller the diameter. The higher the number, the smaller the diameter. So a 22 or a 25 or a 27 gauge are for babies, preemies, little ones. Not 22, but 25, 27 are for peds and babies. And then 18, 16, 14 is what I call like a pencil lead. Literally, it's funny. It's almost as big around as a pencil lead. And you might see that on an ambulance. If you're donating blood, they might use a 16. In the hospital, for a patient who's hemorrhaging, we like to have an 18. In OB, where I did a lot of my practice, our preference was always get an 18 in. And if we couldn't, anesthesia would be kind of unhappy with us. But so we always try to get an 18. And then the smallest size you can use it to still give blood. If you want to give blood, you have to have at least a 20 gauge. So you see those 3 gauges there, and it's a kind of a standard across the board colors, and you'll learn to memorize these. But for me, it's kind of like, when you're guys, you'll appreciate it as a football, call it green 18, blue 22, and then pink's in the middle. So that's how I always remember it. Green 18, blue 22, and then pink in the middle, which is 20 gauge. Let's see. Now, IV devices continued. There is on this slide lists most of the different parts. So I'm going to skip this to the next slide because we've got a picture of all the parts of an IV. So we'll talk about that on the next slide. I will say on this slide at the very bottom where it says intermittent infusion devices, Medlock, Heparin lock. We used to call our intermittent use devices Heparin locks. They now call them Medlocks. So you've probably heard the term Medlock. And as we talked about earlier, if you are administering medications, you always flush before to assess patency. You don't want to start putting medication into a line that you don't even know if is patent, because then the patient's not going to, if it's infiltrated or not working, you start trying to push the med in, the patient's not going to get their medication. So you want to flush it first, test it with saline to make sure it's patent, and then afterwards we flush it with saline again to flush it on through all that cannula to make sure it's all into the patient's tissue. So flush before, flush after. Initial flush, determine patency. Post flush, flush all the medicine through. Okay, here's our picture with all of our parts to an IV, a continuous intravenous device. So you see your bag spike, and it's upside down. Ordinarily when we're hanging an IV, it would be right side up. But you take that bag spike, take the cap off, and you spike your IV bag. That's something you all will be doing this semester for practice, and you will need to be proficient in that. So the bag spike is what you spike your bag with, and then you have the drip chamber again, which ordinarily should be turned the other way. Your drip chamber is that little clear hollow area where you squeeze some fluid in, and that way you can watch it drip. You can watch the drops come out. A regular dropper, it's usually 10, 15 drops a minute. And then you can also get a mini dripper, which is maybe for peds, and 60 drops, in an ml, maybe, but a standard adult one is usually 10 to 15 drops. I said minute at first, I'm sorry. 10 to 15 drops per ml, whereas a mini dripper might be 60 drops an ml for a pediatric patient. So that's how you see your drips. Now, you see a roller clamp there. That's how you open and close the flow, and you actually can control flow like that if you would like to. Now, also want to make note, over on the other right side here at the bottom, I'm going to point my arrow there, and I don't know if you all it'll come across that way, you'll see it or not, but look for the auxiliary clamp in the bottom right of your picture. That is another way to quickly clamp off your IV. You can't control flow at all with it. It's just open or shut. You just open it or close it. But your roller clamp over here on the left is open or shut, but you can also roll it up and down, and it will control the rate. It's not very accurate, and we don't use it much for that anymore, but I used to use it all the time. In the 80s, every patient wasn't on a pump. You guys have the luxury of having all your patients getting IV pumps now, so everything's closely regulated in terms of flow. We didn't have that luxury. We used roller clamps most of the time. So you had to calculate the drip rate, calculate how many mLs you wanted to give per hour, and come up with a number. And I used to have most of the common numbers memorized. I knew for example, 125 ml an hour was 2 drops a second. So, you would, essentially just watch it and then roll up and down and regulate it till you got what you wanted. Again, not commonly used anymore, but you can use your roller clamp for regulating flow. Okay, now you have the needle end, and that's an old. This was an old slide because we have needleless systems now, so that's not really the needle end, but the end of your it plugs into your IV. The IV cannula that went to the patient has a little thing on the end that's open, and that just hooks into it and um, hooks into the actual IV going into the patient. And then you have an injection port up on the top right. So if you got an IV running normal saline, let's say at 50 ml per hour, but yet you want to give some morphine IV push, you can give it IV push through that injection port. When you are given a medication through an injection port IV, you always want to remember to pinch off, take the tubing and pinch off above it. You want the medicine to go, and those injection ports are generally very close to the IV site. So there's not very much tubing between the injection port and the patient because you want them to get that medication quickly. If you just push the medicine straight in and without pinching off back behind where you're given the med, what'll happen is the medication will go backwards and you'll even get it up into the bag and it won't be IV pushed in. It'll just be running in infusion, and who knows how long it'll take to get in. So you always want to, when you're doing an IV push medication, pinch off behind where you're injecting so the medication doesn't go up in the bag but goes into the patient. Okay, administering IV medications. Some interesting things, or important things I should say, to know about administering medications. First of all, if you have an IV bag that's infusing continuously, whether it has some medication in it or whether it's just IV fluid, both the bag and the tubing need to be changed periodically because they do become contaminated by bacteria, especially anything that has sugar in it. And anything with sugar in it is going to become contaminated even faster because obviously that is a medium for bacteria to grow. So usually, and you want to follow your institutional policy wherever you work. The policy may differ somewhat from institution to institution, so you want to follow the policy of the hospital where you work. See, and when this PowerPoint was created, there may be some very small changes, but for the most part, this follows CAMC's policy. Change the IV dressing, and the dressing is what's over the IV site. The clear bio-occlusive dressing, the tape, all is supposed to be per policy changed every 72 hours, or if it becomes wet or contaminated. Now, you want to be very cautious with that. If an IV is someone's a very hard stick and an IV is in a very precarious spot, you want to be careful about taking all that dressing off because it may move the IV cannula around and cause you to lose your IV. So you got to be real cautious with that. But and that will keep a lot of people from changing their IV like they should, but it still should be done. Now the IV tubing should be changed usually it's either every 24 or every 72 hours depending on your hospital policy. Most IV bags with fluid in them need to be changed every 24 hours. For example, if you're infusing normal saline, but it's only going at 50 ml an hour, then you're not gonna run in a whole liter in 24 hours. So even though you still have plenty of saline left in your bag, you'll need to change the bag out, a new bag. We always label the tubing, dressing, and bag so that the next person that comes along can know when it needs changed. Otherwise, it's anybody's guess. Also, it's very helpful if you write on the little site where the IV was started. Like there used to be in the little IV start kits a little tag where you could write the gauge and write the date that it was inserted, and that's very helpful. Otherwise, you kind of have to go back through your nurse's notes and try to find out when that IV was started. So if it says it on the, right over the IV site, that's extremely helpful. We want to be careful not to let IV bags touch the floor and tubing. Bags maybe you don't see touch the floor so much, but tubing, I can't tell you how many times, patients will drag the tubing along or the staff will, and I will tell you one time I saw the tubing fall into the floor, and an attendant had a patient on a carrier, ran over that tubing and just sliced it in half like a knife. And so there was that IV tubing on the filthy floor with a big hole in it where it had been cut in two. So we had to hurry and get that discontinued on someone who was very hard to stick because we contaminated the tubing and put a big hole in it by running over it. So you want to be cautious. Also, I can tell you that, if you've been working at the hospital very long, you know that you'll find that IV tubing literally up a patient's butt crack. You'll find it that they will pee on it, they will vomit on it, it will be laying, and they're incontinent, it'll be laying in it. That tubing gets so dirty. So we want to, again, make sure that's changed frequently and that it's taken care of. When the patient's in the bathroom, we don't want them to sit down on the toilet and have the tubing up underneath them. Now, when you need to give medications, again, you've got an IV hanging or it's just a medlock. In the past, we taught what we call scrub the hub, which is taking an alcohol pad and scrubbing that hub for at least 15 seconds before you administer anything through it. Now, of course, a lot of institutions will have the little things, the caps, the green or orange or whatever color they are now, the little caps that stay on the hub, and those are to protect it and keep it clean. If those the hub caps, we sometimes call them, have been on for at least 5 minutes continuously, they're considered to be okay and you don't have to scrub the hub. If it hasn't been on for at least 5 minutes, you'll need to scrub the hub. So you either scrub your hub 15 seconds before giving medications through it, or you use the little hub caps, as we call them, to keep that site clean. Also important to remember, giving something IV is not the same as giving something PO, and hopefully most of you know that. But I'm telling you that you give it somebody, let's say it's morphine. You can give them an oral morphine pill, and it might take 30 to 60 minutes for them to work. You can give them an IM injection, intramuscular injection of morphine, and it will take 10 to 20 minutes maybe to work. You can give them IV morphine, and it works nearly immediately in a matter of a few seconds. So it works, IV administration of anything, especially IV push, works very, very quickly. The good part is the patient gets the effect immediately. The bad part is the patient gets the effect immediately. You can't take it back. So let's say, for example, you're giving somebody morphine, and instead of a 10 milligram dose, you give them a 20 milligram pill. And as soon as they swallow it, you realize your mistake, that you gave them the wrong dose. Well, it's going to affect them, but you've got a few minutes to think about it. You've got a few minutes to say, oh my gosh, I made a mistake. I gave them a double dose them over what was ordered. What do I do? You got a minute to call the pharmacy, to call the doctor. If you give someone a double dose of IV morphine, you have no time to undo it. You have no time to think. You will have to act immediately. And so giving someone medication IV, the effect is rapid and it cannot be undone very easily. So you want to think very hard, be very careful. You want to be careful about the rate you give it, and check and see, how fast am I supposed to give this medication? So some medications it's very important you give them at a certain rate, some not as important. So for medications that it's not a specific rate for IV push that's ordered, we usually give it over a minute. So for most narcotics, for example, you can give them, as fast as you there's no specific time. So in that case, we will give them over a minute usually. And when I used to give meds with students, especially narcotics, sometimes the patients would say, oh, you can just push it right in. That's what they all do. Go ahead, just push it right in. And the reason that is they get, you just push it in quickly, and they get a real head rush really bad, really quickly. Really good, I guess, if depending on how you want to look at it. And I would always say, no, as students, we teach the students that it needs to be given over a minute, and that's how it's supposed to be given. But they don't want it to be given over a minute especially if they've exhibited any drug-seeking behavior. They want it quickly because it works very quickly. So if you want a fast effect and you want the patient to get the most medication, the bioavailability, it's going to be IV. So, for example, there are some medications that you can't give orally because there is no bioavailability, which means they don't get enough of it for it to be therapeutic. So you have, every med's different. What routes is it available? Almost anything you can give IV if you need to. Now some, a lot of things we don't, but you almost can give pretty much anything IV. But again, it's going to work very fast. Here's also something to remember. If you give something IV, you're going to give far less milligrams or millunits or whatever the medication is. You're going to give far less of it IV than if you give it PO because of the bioavailability. Again, for example, let's go back to morphine. If you are going to give someone morphine, an oral dose might be 10 milligrams, 20 milligrams. Well, 20 is a lot for oral, but let's say 10 milligrams. It might be a dose that you would give. So if you're going to give it IV, you're not going to give 10. You're probably going to give 2. A lot of times the dose for morphine IV is going to be 2 milligrams every 2 hours PRN. There's a huge difference in how it affects the patient. The bioavailability of the oral is less. So the patient swallows the pill, goes to their stomach, there's just not as much metabolized and used by the body. They may take a 10 milligram oral pill, but they may only actually metabolize and use 4 to 5 of it or 3 of it. I'm just throwing that out there. I'm not sure how much, but the bioavailability is much less orally. IV, they get it all. So it's not going to be an equal. Let's say somebody has nausea and vomiting, and you call to get to change the order to IV. You're not going to give it whatever you're going to give oral. You're not going to give that same amount IV. It's going to be substantially less because the bioavailability for IV is going to be much higher. So hopefully that makes sense. But you always want to remember that and be very cautious with that. Okay, I can't get my slide to move. Okay, how to control the infusion rate. So remember a couple slides ago I told you that roller clamps can be used to regulate flow rate. Are they very accurate? No. And if you're going to use your roller clamp, you're going to have to watch it very closely, and you're going to have to pay attention that you're keeping the right rate going because their arm may be positional, the IV may be positional. If they have their hand this way, it may run faster. If they move their arm this way, it might be slower. So again, the inaccuracies for a roller clamp are high. We would not probably use a roller clamp to give any IV that has medication in it. If it's just fluid, like lactated ringers or saline, or D5.5 normal saline, okay, maybe a roller clamp would be okay. But you certainly don't want to give medication because, again, the rate is not accurate on a roller clamp. And you also then have to convert your drops per minute to mLs per hour to, again, if you know that 10 drops a minute is your flow rate, and then you're going to have to give so many mLs per hour, then you got to know, it's not, when I say 10 drops a minute, I meant 10 drops per ml is your flow rate. So then 10 drops per ml is your equals an ml is your flow rate. Then you have to do a math calculation to figure out that rate. So it can be a little complicated to figure that out. In the middle picture, we have what we call a dial-a-flow. A dial-a-flow is this little knob that you turn it back and forth. It's a connection to the IV tubing. It's to be added to the IV tubing, and it's just about 6 or 8 inches long of tubing. And then you dial the number of the mLs per hour that you want in. 60 ml an hour, 100 ml per hour, whatever, or wide open, or completely closed, or somewhere in between. And it's moderately accurate. So we did use these a lot, quite a bit. And again, they're moderately accurate, so they're good for IV, some IV medications, not critical medications. They're good for fluids too. But if you want to be accurate, if you have a critical drug, you want to be very, very accurate, your only solution, your only answer there is going to be to use a pump. A pump is not exactly set it and forget it, but it is at least set it and know that you're getting an accurate rate. So you set your pump rate, program it in, and that should take care of your rate. So those are your 3 possible ways to control infusion rates. Complications of IVs. Anytime, of course, that you puncture the skin, you've provided a means for microorganisms to enter the body, especially if a patient's immunocompromised. If we have a cancer patient, or a patient who's on any kind of medication causing them to be immunocompromised, then we got to remember that an IV is going to increase their chances of, whether it be phlebitis or, or worst case scenario would be sepsis. And as I said earlier, medications administered IV enter the bloodstream immediately. Any adverse reaction is going to occur immediately. So you have to be prepared for that. So when I'm giving something IV, I'm very cautious. I'm thinking. I'm not letting people interrupt me when I'm calculating or figuring out the right rate. Sometimes I'll ask the person, hey, double check this for me. Make sure I got this right. Because you can't take it back. You can't undo it. It's very easy for fluid overload or electrolyte imbalance to occur from excessive or too rapid of infusion of IV fluids. Even if you're just given saline, even if you're just given lactated ringers, you want to make sure you're not giving too much, even if it's just fluid. You don't want to give too much because you can cause fluid overload. And I will tell you, and I always use this example because if any nurse tells you they've never made a mistake, they're telling you a lie. I've been a nurse for 40 years, and I have made my share of mistakes. And the best thing that you can do when you've made a mistake is tell someone quickly and ask for help in getting it resolved. So I was a very, very green nurse, less than 6 months as a nurse, and I worked on the trauma floor at General, a step-down trauma unit. And we got a patient in heart failure for some reason, which is not even what we should have been getting on that floor, but it's a little old lady with congestive heart failure. So I started her IV, new admit. Back then we started our own IVs, and she was hard to stick, and so I got her IV started. I was just finishing up, getting ready to throw all my trash away, and somebody yelled I was needed in the next room, pronto. So I went off in there to check on my patient, see what I needed, got distracted, got back to the patient's room in a little less than an hour. To my dismay, I'd hung 1,000 ml bag of fluids when I started her IV. To my dismay, I looked and the bag was empty. Completely empty in less than an hour. So I had infused 1 liter of fluid in this lady with CHF in less than an hour. And my heart sank. What had happened was, because I got distracted and I got yelled at to come somewhere, I forgot to, when we've started an IV, a lot of times we'll open it wide open just to make sure it's running. Well, so we can assure that it's running correctly and as it should be. And then you'll slow it back down to the rate that you want. And I had forgotten to slow it back down. I just got distracted and didn't finish the job. And my heart sank because I thought I put this patient into, an episode of, exacerbation of her heart failure. So I notified my charge nurse. We called the doctor. They assessed the patient. And they discussed moving her to ICU overnight to watch her, and as it turned out, they didn't have to. She did okay. And so, fortunately for me, that scenario ended well. Patient, by the next day, she was fine. It could have been very different. It could have exacerbated a CHF. It could have caused respiratory distress. It could have, done a lot of things, but it didn't, thankfully. So I was very fortunate. But what's the moral to that story? Finish your job. Have processes in place that you do. It's steps that you do, and that you're not finished until you've done this step. In my case, I just didn't have a system down well enough yet. I was too new to have a good system, and I just hadn't completed my task. So be very cautious because, again, an overdose like that could be very dangerous. And if it had, what if it, even worse, it had medication in it? It didn't. It was just fluid, but it could have been even more serious. Incompatibilities between certain solutions and medications can occur. When you are mixing any two medications, you need to consult pharmacy first if you haven't given those two medications together before to make sure that there are not incompatibilities. There are drugs that crystallize when they come in contact with each other or become cloudy. So you want to follow up on that anytime you're not sure. Nerve damage, hematoma, infiltration, phlebitis, thrombophlebitis, all things that can happen as a complication of an IV. So certainly when you're sticking somebody, you can damage a nerve. And hematoma is just a pocket of blood under the skin that becomes a bruise. Infiltration occurs, as you probably know. Infiltration occurs when the IV infuses not into the vein like it's supposed to, but into the soft tissue around the vein. That's called an infiltration. The fluid is not meant to go into the soft tissue. It's meant to go into the vein. It can be very dangerous to have an infiltration, especially if it's certain medications that are tissue vesicants. So infiltrations can be serious, and when we have an infiltration of our IV, when we notice it, we remove that IV immediately. That's always the first step. Remove the IV immediately. Now, how do we know if an IV is infiltrated? Usually the patient will complain of pain, although not always. But you'll see an extremity that's very cool to the touch. If it's full of fluid, it'll be very cool, tight, shiny. The IV may beep because it's not running. It may be really puffy. Anytime that you see any of those things gives you an indication that the fluid is not running in the IV space but into the soft tissue. IV must come out. Phlebitis and thrombophlebitis are just inflammation of the vein. Thrombophlebitis, of course, means there's a clot somewhere. Tissue damage, compartment syndrome. So compartment syndrome, I think it's on the next slide, so I'll come back to that. Catheter embolism. So your little hollow cannula or catheter or whatever you want to call it that's in the skin, it's attached outside the skin to a little plastic hub that the tubing goes in. When we discontinue an IV, we should always look and make sure that little cannula is still attached to it. And I had always said to students, in my, at that time, 35 years as a nurse, we always check the catheter, but I've never seen a catheter tip not be attached to the IV. So almost was to the point where, like, why do we do this? A couple years ago, maybe 3 to 4 years ago now, we had a baby in NICU that when they DC'd the baby's IV, and it was a scalp IV, which is very common in NICU, they pulled the catheter out, they pulled the end out, and no catheter was attached to it. So the catheter was not attached to the IV. The little plastic hollow end had broken off in the baby's scalp. So that's really scary. And that's the first time I've ever heard of it in all my years as a nurse. They sent that baby to Pittsburgh immediately. I don't know what ended up happening. I really don't. But it was very scary. I can tell you if it's an extremity, which is where you're going to unless you work in NICU, it's going to be an extremity where your IV is. If you see that the catheter tip is broken off, you should place a tourniquet proximal or above the site. So if it's an IV that's in the hand, you should place a tourniquet above the hand and then call the doctor immediately. And that's only if you can feel the catheter. So if you can, like if you take your IV out, there's no tip, and you feel it under the skin there, just kind of floating, then you tourniquet above it and call the doctor. If you don't know where the catheter is, there's no point in putting a tourniquet. You just call the doctor immediately. What we're trying to do is prevent that catheter from floating into the systemic circulation. Air embolism, and this is when air gets in the tubing. I can tell you that you've all seen movies where they were murdering somebody by putting an air injection of air into their tubing and killing the patient. That was always the way to commit murder, especially on a soap opera. That's very hard to do. We do want to always prime our tubing, and that by prime the tubing, it means we run fluid through it so there's no air in the tubing. Tubing starts out just full of air, but we run fluid through it and get all the air out. However, I will tell you that it takes more than what's in a whole IV tubing to kill a patient of air. So you don't need to be too freaked out about it. If there's two teeny tiny bubbles in the fluid and you can see them coming, I've had patients yell and scream, "Get that bubble out! It's coming!" and be all freaked out. Tell them not to worry. It takes all the air that's nearly in a set of tubing to cause an air embolism. So we want to be cautious, but know that it's not easy to do. Signs of air embolism would be all the same signs as a pulmonary embolism. So tachycardia, dyspnea, hypotension, cyanosis, decreased level of consciousness, all same signs as you would see on a PE. If air embolism is suspected, turn the patient to their left side, place in Trendelenburg while on their left side, notify the physician immediately. And I, again, have never seen this happen in 40 years of being a nurse. Now, I said I would talk about compartment syndrome and how that would relate to IVs. So a compartment is just a part of an extremity when we're talking about compartment syndrome. And what happens let's say the compartment is the forearm, the left forearm. something happens to occlude circulation in the hand, so that the forearm is literally no circulation below it. And that can happen from an IV if there's enough damage done and enough swelling in that forearm. Then you can develop compartment syndrome below it, which means the nerve transmission of nerve signal and the transmission of blood flow below that area is obstructed and can lead to something called compartment syndrome, which can be very dangerous. And it comes from massive amount of edema in the extracellular space or the soft tissue that prevents blood flow, compresses nerve movement. So an IV or an infiltration from an IV could theoretically cause that as a complication. Okay, as I told you earlier, clients with congestive heart failure, we want to be cautious with our IV fluids. We don't usually give them fluids with a lot of saline because of the risk of water retention and therefore fluid overload. With CHF, we don't want to give them fluid overload. Clients with diabetes, we usually don't give them fluid that has a lot of sugar because, again, they are prone to hyperglycemia. Lactated ringer solutions, which contain potassium as well as a lot of other electrolytes, should not be administered to patients in renal failure. So tell me, from the second semester, think about why is that? Why is it that your patients with renal failure should not be given lactated ringers? I'll give you a second to think about that. And for those of you guys who don't remember, patients in renal failure usually are very, very hyperkalemic because what part of the body controls our potassium level? Where is it potassium excreted and retained in the body? Through the kidneys. So if you have renal failure, you're prone to hyperkalemia because your kidneys are responsible for regulating potassium. If your kidneys are not working properly, they can't regulate potassium. So hyperkalemia, we know, is very dangerous. So we would not want to do that give lactated ringers or lots of it to a patient in renal failure. Also, signs of hypervolemia or fluid overload are listed on this slide. Edema, particularly of the feet, hands, and ankles, difficulty breathing while lying down, crackles on auscultation, high blood pressure, cough, JVD, jugular vein distension, dyspnea, strong rapid pulse, all signs of fluid overload. So keep that in mind. We can overload our patients with fluid very easily. All right, this is where the information is pretty much new. I know this is blank, but we usually talk about this in class quite a bit. So as you listen to me, you might want to jot down a few notes. And if you have questions, please jot that down also, and I'll be happy to go over any of this with you next week if you have any questions. So in IV fluid types, there are 3 types of fluid in terms of the proportion to what's in the vessels. There's hypertonic, hypotonic, isotonic. Now, hypertonic fluid has a higher percentage or proportion of a substance than what's found in the bloodstream. A higher proportion or percentage of a substance than what's found in the bloodstream. Hypotonic solution has a lower proportion of a substance or percentage or proportion of a substance than what's found in the vessels. Isotonic is the same, it is equal. So for example, let's talk about normal saline first. Normal saline is 0.9% salt in water. That's all it is. Normal saline is 0.9% salt in water. So our blood has 0.9% salt or sodium in it. So if we give normal saline, we're giving an isotonic solution to our patient. If we give normal saline, we're giving an isotonic solution to our patient. It is the same proportion or percentage of salt to what's already in the body, in the blood, let's say the blood. The blood contains 0.9% salt or saline. Normal saline is also 0.9, so that's an isotonic solution, right? D5W is the second fluid that is isotonic. D5W is 5% dextrose in water. 5% dextrose or 5% sugar in water. And it is also isotonic to the blood. So if I give you D5W, it's the same amount of sugar that's already in your blood, 5%. The third fluid that's isotonic is lactated ringers. You can call it RL, you can call it LR. It's the same, ringers lactate, lactate ringers, same thing. This has a multitude of different substances in it, but they're all a lot of electrolytes, a lot of minerals, but everything that's in it is isotonic to what's in your blood. Everything in lactated ringers is isotonic to what's in your blood. So every fluid is a derivative of one of these three fluids typically. Every fluid is a derivative of one of these three isotonic fluids. For example, we have normal saline, which is isotonic, but they also make 0.45 normal saline. Well, it wouldn't be normal saline then. It would be 0.5% saline. Or they also make 0.225 saline. So 0.45 is half of what's in your blood, right? If 0.9 is isotonic, then 0.45 is half of that. So that would be hypotonic. So if I was administering a hypotonic form of saline to my patient, it would be 0.45 or 0.225, which is 1/4 normal saline. 0.45 is half normal saline. 0.225 is quarter normal saline. So those are going to be hypotonic solutions because they're hypotonic to what's in your blood. They're hypotonic solutions because they're hypotonic to what's in your blood, which is 0.9. So hopefully that makes sense to everybody. There is, D5W, we don't really have a hypotonic form of D5W, but we do have hypertonic. We make D10, they make D50. And those, of course, would be hypertonic solutions. Hypertonic, because D10, that's 10% dextrose, or D50, 50% dextrose. That's way more sugar than what's in the blood. What's in the blood is D5, 5%. So D10 or D50 are going to be a hypertonic solution. Then there's lactated ringers, of which lactated ringers is lactated ringers. There's no formula that has less or more. It's always an isotonic solution. So now the question is, when do we choose to use those? So why would we choose to give one over the other? We talked about how to differentiate between isotonic, hypotonic, and hypertonic and hypotonic. So when do we choose to use them? So lactated ringers is used to pump up intravascular volume, as in a hemorrhage. If my patient is hemorrhaging, if they're bleeding to death, or if they have no fluid in the vascular space or their blood pressure's bottomed out, we use lactated ringers. Because what happens with lactated ringers, it goes directly into the vascular space and it stays there. This is key. Lactated ringers is used to pump up intravascular volume because it goes in the vascular space and it stays there. I mean, it doesn't stay there forever, but it stays there for a while. We don't give normal saline for hemorrhage because normal saline will go to the vascular space, but it won't stay there. It will diffuse from the vessels, through the vessels. It'll leach out and diffuse out into the soft tissue. So normal saline is for replacing volume after vomiting, diarrhea, dehydration. That's when we would use normal saline. Let's say you come into the ER with nausea, vomiting, diarrhea. You're very dehydrated. We check your specific gravity. You're very dry. But you're dry everywhere. You're dry in your vessels. You're dry in your tissue. You're dry everywhere. So we give you saline because it replaces your fluid everywhere. That's our choice for our patient with nausea, vomiting, diarrhea type dehydration. If you are bleeding or something makes your blood pressure bottom out, you have nothing in the vascular space. What other example would that be beside bleeding? Well, for example, when you get an epidural, and we'll talk more about this in OB, but when you get an epidural, one of the odd side effects of an epidural is it causes a blood pressure drop. It causes a drop. It causes systemic vasodilation, so your vessels dilate and therefore the pressure drops. So we need more fluid in that vascular space to make up for the dilation of the vessels. So we use lactated ringers, because lactated ringers goes to the vascular space and stays there, at least for a while. Not forever, but for a while, long enough until we can, get blood going or whatever we need to do. So lactated ringers is the treatment for hemorrhage or some kind of intravascular collapse. Normal saline is our treatment for nausea, vomiting, diarrhea type dehydration. D5W, which is our other isotonic solution, is given to replace small amounts of glucose when needed. Let's say you're in the hospital having a bunch of tests done because you've been sick, and you're NPO for 3 days. And we need you to be NPO, but we don't want your blood pressure, or your blood sugar to go to 0. So we'll give you an IV with D5W or D5 something else. But we'll give you some D5. That is 5% dextrose in water to replace small amounts of glucose when needed. Now, there are various fluid combinations that you will see in the hospital very frequently. So you'll see D5LR, which is a combination of D5 and LR. You'll see D5 1/2 normal saline, which, by the way, is the most common IV fluid in use, is D5 1/2 normal saline. So look, you'll see the list there. Let's talk about each one of those, and let's talk about, are they hypertonic, hypotonic, or isotonic? Which is it? D5LR. So our D5 is isotonic, right? Our LR is isotonic, right? So that's an isotonic fluid. D5 1/2 normal saline. Our D5 is isotonic, but the half normal saline, you can also put there, instead of D5 1/2, you may also see it as D5.45 normal saline. So the D5 is isotonic, but the 0.45 is hypotonic, right? So that's a hypotonic fluid. 0.9 is isotonic, so D5.45 normal saline will be a hypotonic solution. 0.45 normal saline, just plain 0.45, is going to be hypotonic. D5.225 normal saline. So it's D5, 5% dextrose with 0.225 sodium, which is a hypotonic. So you have a hypotonic solution. D5 normal saline. D5 is isotonic. Normal saline is isotonic. So you have an isotonic fluid. D10W, D10 in water. So that's D10. That's going to be hypertonic, right? Because D5 is isotonic, so D10 is going to be hypertonic and contain a higher percentage or proportion of dextrose than what's found in your blood. Very good. So would there ever be a case where you might use a higher than 0.9 normal saline on a patient? Sure. So let's say you have a patient who comes into the hospital and they have a sodium level of 120, which is extremely low. By the way, if you don't know the normal sodium level, you need to know it. That's a lab, that is a need to know. 136 to 145 is, for most reference ranges, that's going to be your normal. And 120 is almost life-threatening low. And your patient has a sodium level that's critically low. So we can give them saline, but if someone is very, very low in something, and I'm kind of having I wish I could show you with my hands, it would make more sense, but if someone's very, very low, and we just give them a middle-of-the-road fluid to replace it, it'll bring it up slowly. If they're way down here, and we give them an isotonic solution, eventually that fluid will come up, and eventually they'll be close to normal again. But what if we gave them a hypertonic solution of like 2 or 3% saline? Instead of 0.9, what if we gave them 2 to 3%? That's double or triple what's normally in the body. Wouldn't that bring their extremely critically low sodium level up faster? While 0.9, which is isotonic, would bring them up slowly. If we need them to come up critically fast, we might give them 2 to 3% saline to bring them up much faster. Hopefully that makes sense. Think of the proportions that we're talking about. So yes, you might see fluids that are very hypertonic to bring up somebody that's very hypotonic. Because remember, isotonic's what we're shooting for in the middle. Isotonic's in the middle. If you're very hypotonic, you want to give somebody something hypertonic to bring them back to isotonic in the middle. Again, I know it's complicated. Please see me if you have questions, but it's real important for you to remember about normal saline, when we would choose to use normal saline versus when we would choose to use lactated ringers. If you don't understand that, please ask me in class to explain it again where we can communicate back and forth. But it's going to be really important for understanding the rest of the course, especially in OB. All right, the next slide is about vascular types of devices. We've talked exclusively about your peripheral IVs so far. That's what we've been talking about. So short peripheral catheters, that's what we've been talking about so far. Just a short-term IV, usually stays in the hand, or no more than 3 to 4 days, or the forearm. You can use an antecubital, and you can use a foot IV. We used to put IVs in the feet all the time. Now, because of circulatory issues and things like that, it requires typically a doctor's order in order for a patient to have a foot IV, but we used to do it on the daily, just about. Midline catheters are like PICC lines, but a little shorter term. We're going to talk about PICC lines. We'll talk about central lines, and then ports. So peripheral IVs, as I said, that's all what we've already talked about, up to about 4 days, and you got to start a new one. They're in the hand, forearm, started by an RN, and some LPNs have been trained to start IVs as well. This is, again, institution dependent. Remember, veins cannot be used in patients. Now, what this slide means is, like, sometimes a whole extremity can't be used in certain patients. For example, you've all seen someone have the restricted limb bracelet on one arm, and that usually means they've had a mastectomy on one side, with or without a lymph node dissection. Maybe they have paralysis of the upper extremity. Sometimes with paralysis, they won't want you to use those extremities. If they've got a dialysis graft in, then you don't touch that. I'm scared to death of those things. Those are the biggest honking things that are in, under the skin, in the wrist, and they're huge. And I'm scared to death of disturbing one of them for hemodialysis. Now, back to a mastectomy. Why can you not put an IV in the same arm as someone who's had a mastectomy? Okay. If it's just a mastectomy without a lymph node dissection, you can. You can still do it. But the problem is, a lot of times the assumption is if you've had a mastectomy, you've had a lymph node dissection as well. That's not necessarily true these days. So if you've had a mastectomy with a lymph node dissection, that means they've taken all or most of your axillary lymph nodes. If they've taken those out, and what they do is they take them looking for cancer. They're looking to see how many, if any, have cancer in them when they do the mastectomy. So once those are missing, never to be, you never have those in your arm again. The job of the lymph nodes in the extremity is to regulate extra fluid in the arm and to remove waste products from the body. So let's say you cut on a normal person. Let's say you cut your finger. You've got bacteria in your finger, you've got dead tissue, you've got these things in the white cells called, different kind of white cells called macrophages, or, I call them the Pac-Man of the bloodstream, and they come and they eat all that waste, the bacteria and the dead tissue, and they haul it away, and it goes into your lymph system. And from your lymph system, it drains into your blood system, and then your body gets rid of waste. If that lymph system isn't working, then that system of clearing bacteria and dead tissue doesn't work. Also, that lymph system regulates swelling in your extremities. So if if your arm, you hold it down all day and it's full of fluid, you move your hand around, pump your hand a few times, your lymph system will take care of that extra fluid. So if we have those lymph nodes removed, the ability for that to happen is gone. So therefore, a patient, we would avoid sticking them because there's no ability for that arm with that lymph node dissection to rid itself of bacteria, maybe from the lab stick, or dead tissue. So we avoid that extremity in patients who've had mastectomies with lymph node dissection. Lymphedema is what results in those patients. Their arms can get really swollen. They can get infections in that extremity easily. Some patients get it, some patients don't, but you never know which patient that's had a mastectomy is going to get it. And then we talked about the rest of that. Okay, the midline catheter is sort of like a PICC line, but a little less than. It's somewhere between a peripheral IV and a PICC line. It is inserted through a vein in the upper arm. It's inserted by IV therapy. IV therapy is trained to put in midlines and PICC lines. It can stay in 1 to 4 weeks, and you can see in the picture that it doesn't go quite to the distance that a PICC line does, but it goes almost up to the subclavian, or up to about the subclavian, but not down into the vena cava. So the rest of these are all types of central lines. A central line is a vascular access device that's placed in the central circulation, specifically within the superior vena cava near the junction of the right atrium. That's the placement of the end of the catheter, is near the junction of the right atrium. We got to do a chest x-ray to confirm placement of these things. And PICC lines PICC stands for peripherally inserted central line, and then there's other type of central lines as well. So these are a central line and a PICC line somewhere in between a peripheral and central. It's not a central line. The rest of these are all central lines. The biggest problem we see with central lines is bloodstream infections. Look how we're very close to the heart, very big vessels. Any bacteria that gets there is in the central circulation immediately. So these are a big deal. PICC lines are very common now because they're peripherally inserted. They're a little bit less critical. They're inserted in the usually antecubital area, or like a little bit above the antecubital area, and then they're threaded by ultrasound all the way up to the right junction of the right atrium. And they can stay in long term. So if a patient needs to go home and have 6 weeks of IV antibiotics at home, they can do that and be taught to give the antibiotics themselves or have home health to do it. But it is a type of central line that can be placed by an RN in IV therapy who's been specially trained to do it. You have untunneled and tunneled central lines. You don't have to worry about the difference. One, it's just basically where it's entered the skin. But you have different types of central lines. You can have a central line in the subclavian. You can have a central line in the jugular. You can have a central line via the femoral artery. So, or femoral vein rather. I didn't mean to say artery, vein. Sorry. So different possible places to put in a central line. Central lines are put in by physicians or surgical residents, and they're usually done in surgery. The tip resides in the superior vena cava. Again, like all central lines, chest x-ray confirms placement. So I'm not even going to go through tunneled and untunneled because you don't need to know that. An implanted port. A port, when you have a port in, you don't see any part of it. It's under the skin. This is for chemo patients who are getting long-term chemo. Hickman is the most common type of implanted port that I can think of, but there are several different kinds. But it's a little port that is implanted under the skin. You might see a lump where it's going to go, usually on the chest somewhere. But it is can stay long term. It can stay a year, it can stay longer. Until the patient starts to develop problems or infections, it can stay in. It's surgically implanted, and then the patient can get their medication through it, and I'll tell you how in just a minute. I'm going to back up just a minute, and I can't back the slide up, it will erase what I've recorded. But on the slide where it showed, multiple lumens of a central line, the advantage of a central line, when you got regular IV, you got one tubing. Whereas on a central line, you've got like 3 little pigtails, or 1, 2, or 3 little pigtails coming off of it. So you've got 3 different, ports there. You can maybe put blood in one port. You can maybe draw labs out of one port and give your fluids in one port. So it gives you a lot of flexibility with those central lines. An implanted port usually has 1 or 2 lumens, or 1 or 2, but I've seen mostly 1 for this. What happens is there's a magnet under the skin, and you hold a magnet up to it, and then you stick right where the magnet is, and you go into the port. I think I've got a picture of it. Yeah, here's a dual lumen port, um, where you can see it's implanted under the skin. There's a magnet that helps you know where to stick. You stick it in there, and it goes into the opening, and then you check for blood return to make sure you're in the right place. You can give medication, chemos through that port. We always try to give chemo through a central line, so you're not going to have problems with infiltration like you are with a peripheral line. There's too much of a risk of infiltration with chemo and a peripheral line, because if you infiltrate an IV with chemo, you could lose. I've seen patients that lost an arm. It damaged the tissue so severely they could lose their part of their arm, or part of their or all their arm. So chemo is mostly given through central lines or through some kind of implanted port like this. Then last, hemodialysis catheter is a very large lumen catheter for implanted under the skin for hemodialysis, usually somewhere near the wrist. The big risk again is catheter-related bloodstream infections for sure, because the bigger the access, the bigger the possibility of bacteria getting in. So sepsis is the main complication of a central line of any type, or a hemodialysis catheter, or an implanted port. Any type of central access device, your complication is going to be sepsis and possible death. They can be very dangerous. Again, their convenience is great, but you got to make sure they need them. You don't want to put one in somebody that doesn't really need them, because the risk of bloodstream infection and sepsis is very great. Okay, remember, interventions to reduce infection risk. Clean a needleless system before use with antimicrobial. Yes, scrub the hub, or use the little hub caps. Do not tape connections between tubing sets. You should be using, if you've got multiple sets of tubing that you've hooked together, they should fit well. You should never have to tape them. They shouldn't be loose. If they're loose and you have to tape them, there's something wrong. You don't want to do that. Use evidence-based hand hygiene, very important. Also very important, and I know I'm in the minority here, but when I was practicing, we never unhooked a patient's IV, ever. And now they do it all the time. If a patient wants to go to the bathroom and they've got a pump, they just disconnect it. They go to the bathroom, and I'm shocked sometimes that they're doing that, because IVs are supposed to be a non-disconnecting system. Every time you disconnect tubing, you run the risk of introducing bacteria. This is supposed to be a closed system. And what's even worse is a lot of times when people do disconnect it, they don't even cap off each end. The end that goes into the other end, it's sterile. And so if you just disconnect two IVs and just throw the ends down, you're going to have bacteria city. So at the bare minimum, my best choice, my best advice, don't disconnect the IV, even if the patient has to take the pump down the hall. That won't hurt them. Or push the pump for them if you're worried about safety and their steadiness on their feet. Don't unhook the system. But if you must, plug off each end very securely with a nice male-female connector, so that you don't contaminate it. And I always keep those in my pocket for that reason. But ideally, do not disconnect the system. Not what we want to do. Thread them through their gown, or now you all are lucky enough to have the gowns that have snap gowns. We didn't even have snap gowns, so we had to take their IV through their gown and all that stuff. So you're very fortunate. Please avoid disconnecting when you can, and if you must, then plug off. Use plugs to plug off your IV. Lastly, alternative sites for infusion of medications in an emergency, or in an intensive care situation. A-lines, arterial lines. In ICU, you'll see A-lines put in. So those are arterial, and they can use those just like they can central lines. But those are, again, an ICU only thing. Intraperitoneal infusion, that's mostly for intraperitoneal dialysis. Subcutaneous infusion, anybody who knows about insulin pumps, those are infusions, continuous infusions of insulin via the sub-Q route. Intraosseous therapy, and I'll be honest, I've not ever seen this, but they use large bones to access when they need to give fluids very quickly to access blood. And that is done by paramedics, and it can also be done in the ER or by physicians. But if you ever get a chance to see it, some of you guys may have seen it. I have not. Intraosseous therapy. So that is the end of this presentation. Any questions or concerns that you have, please feel free to jot down questions, and we will go over this in class next week if necessary. Hope you're having a great weekend, and I will see you guys next week. Thanks.